Welcome everyone. Welcome everyone to the meeting today. We're getting a slow start. We're working through some technical issues. I think we've got those resolved now, and we want to thank KY-AVERT for the use of the room as well as the technology and also helping us get Zoom working. So if you were with us the last time, we had problems with Zoom. It wasn't from KY-AVERT, it was from UK. They canceled our account. And then when they restored it, they didn't restore all of our registrants. So we had a lot of problems, and we worked through it, and would like to thank Catherine Hine, who was here to help us get through that nightmare for me. So thank you all. And with that, I'd like to introduce our first speaker, and thank you all for coming today. An introduction to Kentucky's Advancing Violence Epidemiology in Real Time, KY-AVERT. And our speaker today is Jacqueline Seals, who has her doctorate in public health and is a senior epidemiologist with the Kentucky Injury Prevention and Research Center. So with that, thank you.
Good morning. So as Steve said, I'm going to introduce you guys. This is our hard launch for KY-AVERT. We were funded in September. And just to go over what I'm going to be presenting on today, first, what is AVERT? Because I know probably most of you have not heard of that project just yet. Our big goal is getting the data out there. So how can we partner with you? I'll go over some data definitions or data, just our data. And then if we have time, we'll probably have time. I'll go over some of our data outputs, what kind of data we have, just so you guys can have a brief look at what we have and how we can partner. Before I start, because I may talk in acronyms, I'm notorious for it, I put a few of our definitions that I may refer to over here on the first screen. So AVERT is Advancing Violence Epidemiology in Real Time. If I talk about any of these other ones or they're on the slide, I just wanted you guys to be familiar with them from the start. So first, what is AVERT? We were funded in September, and from the CDC, we are housed at the Kentucky Injury Prevention Team, Prevention Research Center, and our team consists of me as the PI. We have Dana Quisenberry, which I'm sure most of you guys have heard of her, Andrew Ferry, who is a genius in essence, and then our analyst, Rebecca Day. She's a new hire, so we're very excited to have her. Our focus is on the ED visits and rapid ED visits for violence-related injuries, including sexual assaults, interpersonal violence, youth violence, intimate partner violence, intentional self-directed harm. So this is not necessarily what we're funded for, but because we have such a great partnership with behavioral health, we made sure to include that, and then child abuse. We also are looking at firearm-related injuries, regardless of intent, and mental health conditions. And I will say this on numerous occasions, no one on our team is a mental health expert, so most of this we're still learning. So please forgive us for the mental health if we're not completely defining things correctly. And we will take any advice on how to define those better with our data outputs. And on the call today, I do have Andy, who he should be on the call. So if there's any questions that I can't answer, he probably can. Our goals of AVERT is to improve the timely surveillance data for people for intervention purposes. So with our data, as you'll see, we use hospital ED data, and then we also use Essence data. So to help get the trends out there, try to get things out as quickly as possible, identify risk factors as quickly as possible for those who are doing the work in prevention. We are obviously doing violence-related injuries, firearm-related injuries, regardless of intent, and ED visits for mental health conditions. And so that's why we're here today, is to talk about how we can partner with you. We also want this data to be used. We don't want to just sit on it. So we are going to be working overtime to work on getting our reports up, getting dashboards out so that there's timely dissemination of this violence for intervention. We hope that this will help foster new projects, will support current projects in the state, and to help with the more targeted groups that we're missing right now. So that being said, how can we partner with you? We can do one-time data requests through the KY-AVERT website. You can go on there to do data requests. I'm sure you guys have seen this before. If you guys want ongoing data requests, just reach out to me and we'll get you in our queue to do that. We can do it for almost any of the spectrum of data that we're doing by region. And I'll have some examples of the types of data reports that we'll do later. We do currently have one with behavioral health where we send them a weekly report of the suicide trends or the self-harm trends amongst youth and for the whole state, so they can be as on top of the problems as they occur. We don't currently have data published on our website just yet, but like I said, we will be getting that up as soon as humanly possible, and it'll be on the KY-AVERT website and under the KY-AVERT resources page. And then other things that we can do are meetings like this. Like I said, just to get ourselves out there. We're a very new project, so we're just trying to get out there, get the data used. And here comes the nitty gritty. I'm sorry for a lot of words, but I just want to make sure you guys know who we are, what we work with, our data that we're using. We are using the hospital discharge data, so like ED data. We're mostly looking at the burden in the EDs. This data is available for all hospitals in Kentucky. We base it mostly based on the ICD-10 codes. So that's why might be some questions of how we're defining things, because we're still learning. We also use Essence data, which is the syndromic surveillance system. It collects data from all the partnering states in the state, all the partnering hospitals in the state of Kentucky. It is near real time, so typically within 48 hours of an encounter. It's the glory of that one. It uses a combination of chief complaints, ICD-10, CM, discharge codes, SNOMED, CT codes, and it can be used to identify public health related trends, patterns, temporal spatial anomalies. And I said, we have a person on our team who is already doing this with so many other data sets, including intentional self-harm. He works with the overdose. He is a genius. I'm going to just leave it at that one. But we do have some limitations with our data, to be expected. The ED data, it's to estimate the burden of cases in the ED. We don't have a great definition in our data discharge set. So at the moment, based on recommendations from our state, the data holders, we include all cases seen in the ED and inpatient care at this time. We are hoping to help define that definition a little bit more. It's just still not quite there yet. There is also a timeliness concern. This data is got about a quarter lag. It has to be cleaned, it has to come in, and then it's when it comes to us. So we can only give this out about 1 quarter behind, sometimes a little bit longer, depending on issues. Essence limitations, I said it is very timely, but there are only 89 out of about 105 hospitals who participate. It's not suitable for case tracking, precise counts. We have to go through some data cleaning, deduplication, things like that. And it's not considered accurate as accurate as administrative claims data, which is the hospital discharge data. And it's usually considered preliminary data. So depending on what your needs are, we will work with you to decide what data output will come with. To give you just a little bit of a perspective of what we're talking about when talking for coverage for the syndromic surveillance hospitals, you can see where they currently are not. I do not believe there is a hospital in all of these counties, because there's 120 counties and 105 hospitals, but you kind of get the picture there for that one. When we're talking about case definitions for the ED, we're talking by ICD-10 codes. The assault and firearm codes are defined by NCHS, and we actually pulled them straight from the CSTE website. it's very clean, very easy for us to work with. Mental health crisis, we defined it as any mental health code in the data set, and specific ones that we used are listed here. I will say again, and I will probably say this repeatedly, we are not mental health experts, practitioners, so these codes may not be the best definition. They may need a broader definition, but for this data set, for this presentation, this is what we're going to be using. And for our syndromic definitions, all of these codes are active at this time, and I say active at this time, given one of them, I believe, just came active this week. So yay for all of the being active. They all are. Yes?
Would you all consider adding substance use disorder codes or non-fatal overdose codes?
So,
is there a correlation between mental health and substance use disorder?
yes, and I totally agree with you on that. KY-AVERT is funded for OD2A, which does have that, and so we partner closely with them. We are not, our project is not for substance use, but we do work with OD2A. So yeah, just to kind of get into this, these are all new. They're all, at this point, unvalidated, loosely terming unvalidated. They have been validated, but as you can see, they're all version 1s or very low versions, where if you are looking at some of the other code definition codes in the syndromic data, there are a lot more, they have higher version counts. So first question, does anyone have questions about how to partner with us, what we are, and then otherwise I'm going to get into the data.
Question, you're at KY-AVERT, so you
Yeah.
have access to Julia Costas. Are you linking to any of our Kentucky Trauma Data Bank data?
Not at this time, but it has been discussed. Yeah.
It would seem logical that you would, and I know because we use some of that same hospital discharge data.
Yeah.
Which comes from KHA.
Yep, and we have access to Julia and Elena, who does their analysis. But at this time, we just are not linking it to the trauma registry, but it has been discussed. All right. So I will say that if we do the data partnering, and for the rest of this, we do have the state requirements of we cannot release numbers less than 5. We cannot release calculations based on values less than 10. Those are just not suitable and violate our data use agreements. Okay, so here's what everybody actually wants to look at, the data, right? I personally love the data part. This here is for violence-related ED visits, and again, this is all inpatient and ED visits. As you can see, let me see if I can move the top screen here so you guys can see it just a little bit better. I actually don't know how to do that. I'm so sorry. Oh, there we go. Perfect. Just stick this here in the middle for you guys so you can first see what the numbers are looking like. We're really lucky. They've been going down, right? We do have in those individuals 24 and younger, we did see an increase over here in 2022 while everything else is going down. So in the 10 and under group, it went from 54 to 65. Still not as the highest, but it's not a trend that we want to see. In the 11 to 14, it went from 580 to 762. And in the 15 to 24, it went from 3,166 to 3,304. These are not trends that we want to see, but overall, luckily, the numbers are going down. Other trends that we see here are in the races, in our race, the others, the non-Black, non-white groups. We do have to group them together for small numbers, but those numbers are also trending upward. That is really not a trend that we want to see as well. And our mechanisms of other mechanisms. So this is, drownings, anything that's not listed here, that's also trending upwards. And one of the other trends that I think is interesting, that I found interesting, I don't know if you guys will find interesting, is when we started here in 2017, males were seen more often than females. Over here by about 2020, it switched. And females are seen now more often than males. And while this number is still going down, it's not going down at the same pace as the males. And it is also concerning for me, just to think about.
Can I ask a question?
Yeah.
So does violence related, is that inclusive of child abuse and neglect, or is that a different category?
So it includes all of the ICD-10 codes that I had listed previously. It does not include all of the child abuse and neglect ones. I just didn't have time to pull out all of those codes because some of them fall outside of the violence related because they fall in that neglect category. But we can certainly pull those numbers. Yeah.
The child abuse and neglect codes are on the CFP website.
Okay, yeah, I just didn't have time for this presentation to pull those.
I was just letting.
Yeah. I was gonna say, I think you were the one who developed the resource. And I do hear somebody's car going off, if that's, sorry, I didn't mean to like alarm anybody, I just hear that in the background. Okay. And then here we have our rates by county. Most of these counties to be expected. Most of these counties are to be expected. For me, I do want to highlight down here, Clay County. That one is, I don't know what's going on in Clay County, y'all. It is higher than I would expect it to be, at about a 70 per 10,000 population. And I'm going to share my next. Okay. We also have these reports that, as I said, Andrew Ferry, he created. This one is, I would say, like I said, it's not quite fully ready to be used. It has some cleaning that it still needs to be done, but we can still talk about it with the trends. Looking at the percent-based, so the percentage based of assaults, neglect, ED visit trends per population of the ED at that time, and then count-based. And if I say anything incorrectly, I am going to pop Andy up here on the chat and see if he can correct me because he's smarter than I am. So just to kind of give you some ideas, look at our intimate partner violence trends over this time period. This is sexual violence trends, and these are the percentage of the hospital population at that time. Then looking at the counts, as you can see, the sexual violence trends have been increasing. That's what the red bar means, is it's increasing. Our youth violence trends and our child and abuse neglect trends have also been increasing. And this, you do have the CDC syndromic definition of child abuse and neglect. And then we can look at this by map. As we can expect, you know, Jefferson County tends to be higher with all of these. But then we also have some up here in the northern Kentucky and down here along the, is that 64? I don't remember what highway that is, but that follows that highway right there. So that's some interesting trends that we might be able to point places for interventions. Our sexual violence trends and our daily counts here by county. And if anybody wants to look at this, wants me to stop on a specific map to look at or a specific data trend, just let me know. I'm happy to, we have time, I'm happy to stop so you guys can see this a little bit closer. And our child abuse and neglect. And I'm not gonna, like I said, I'm not gonna necessarily speak too closely on these trends at this time because this is our first round of this data. It is, still needs to be a little bit cleaned, and then we'll be able to speak a little bit better on that. And then here comes the firearm ones. This one is fun, and I say that sarcastically. I work with this data all the time, so it's, for me, it is just second nature. We did see a spike here in 2020 that has thankfully been decreasing. There was actually a 46% increase in the firearm visits in 2020. This increase was attributed mostly to the unintentional injuries and assaults, and children under the age of 14 saw an increase in firearm injuries here. They're the ones that are still increasing. Oops. When it comes to this data. And this, when we talk about the intent, we do not see as much self-harm with firearm injuries in the ED. That's mostly because most of those end up in death, unfortunately, and I will just be blunt about that one. The other area that we have some concern in is this increase in the non-white populations. That is of concern for us. It is luckily going down in the Black communities, but it is still increasing and relatively high in this non-Black, non-white populations. And here we have our firearm injury rates for 10,000 residents. As we can expect, Jefferson County is high, but we also see some high numbers over here in Owsley, Clay, and Leslie County. And yes, I do have syndromic data for all of this, so I will be switching these back and forth. Oops. Sorry, let me get control of the screen here. And these numbers are not as necessarily easy to look at. They're a little bit all over the place when it comes to the data for firearm injuries. And it's mostly stable or decreasing across the state. This is firearm injury overall, our unintentional injuries. We do see some increases here, and the intentional injuries are stable or non-existent. And I'm really going to be sorry because I have to say for the, again, for this next part of the slideshow, I am not an expert in mental health related visits. So if any of these numbers look off to you, concerning, please talk to me to help me get a better definition. So for me, the numbers are decreasing. That's mostly what I find to be the most interesting. Mental health diagnoses are not exclusive, meaning if you have anxiety, you can also have depression. So they may overlap in the same category. And these numbers may not add up to the total because they are just a select population of anyone who had a mental health diagnosis. We did see a rise in 2022 among those 14 and younger and those 65 plus, and those who were not identified as white or Black. We saw increases in that. Disorders that have seen increases in the ED visits in 2022 based on their ICD-10 codes include anxiety, ADHD, and impulse disorders. And again, these are based on if there was any diagnosis of a mental health crisis, so they could have been seen for any number of reasons other than just mental health. There we go. Sorry, don't know what I was doing there. And by county, we can see where we see the larger burden of these mental health visits over here in Breathitt and Owsley and don't know what happened to the words in that one, and I don't know the map by memory to tell you which county that is. Okay, thank you. And then we also see up here in Grant, we see some increases over here. I think predominantly in the Appalachian communities. And this is 4 to 5 year time period. So this kind of makes sense because we, saw the floods over here and then we saw tornadoes over here in this time. So this all makes perfect sense to me. Okay, so then we'll go over here to our syndromic data. And as you can see, we've been seeing mostly a decrease in these mental health conditions. We just chose the top couple mental health diagnoses for the Essence report. And then we can also look at this by county. These are the trajectories that we're looking at for like the 7 or so days. Anxiety disorders over here, and depressive episodes. Any questions, things that stand out to you all?
Do you have any theories why the counts are so much more, encouraging than the percentages? Like, all of a sudden we're losing people or population to count.
So the percentages are based on necessarily the burden of the hospitals at that time. So the percentages may be high because they're seeing, they may be seeing lower burden of hospital population. And that's why the counts might look better than the burden or the percentage of the.
It's not based on population, like for 100,000.
No, that is based on the population of the hospital. Yeah. I hope that makes you feel better.
It's total ED visit census. If y'all can y'all hear me?
Yes.
Okay, great. Yeah, it's just the total ED visit census. Like the proportion of encounters that meet syndrome definition X compared to everyone that shows up at every emergency department from that county, or in any emergency department from that county.
Also, based on an increase in a lot of like physical stuff from natural disasters.
Yeah. But these here are just the past 7 days. So when we're looking at the stuff that's on the PowerPoint, the maps on the PowerPoint, that is over a 5-year time period. This is just in the past like 14 days, something like that. Okay. All right. And then, so that is, for the most part, what I have for the presentation. I do have more data that we can discuss on the Essence. And if you guys have any questions, want to talk to me about any of this, I know I went through that really fast. I'm notorious for that. I'm sorry. I do have more data that we can talk about, we can look at, but we can also just, have a conversation about the numbers if you guys want me to go back and look at anything.
I've got a mic if anyone has some questions.
And are there any, let's also check to see if there's any questions in the chat here too. Down here. Okay.
I believe we do have a little more time if you had any data that you wanted to share or additional data.
I have one more question.
Yeah.
On the firearm data that you had there since 2020, it looked like there had been a pretty significant decrease in the firearm-related visits from 2020, 2021, 2022. Is that also based on the percentage of what other type of visits for the ER during that time period?
Not necessarily. I haven't looked at the whole, at the total ER data, so I can't tell you exactly what it's, if it's the whole population. As you can see here with the assaults, we saw, an increase in 2020. It's still pretty high there comparatively. Luckily for us, most of our data is decreasing. That's what we wanted to happen, right? We want the data to, we want the preventable stuff to decrease. We'd like all of it to decrease, but that would mean a decrease in population, I think. So we are not necessarily, like, it doesn't necessarily mean that it's correlated to what the hospital population looks like. I can't necessarily speak to that.
So it actually could be a positive, like public health related type decrease in.
Yeah, it could be based on interventions. It can be based on a lot of things. And we do know that there's been an increase in that concern for the firearm-related ED visits, working on trying to prevent any firearm-related injuries. All right. Any other questions? There's the chat again. Okay. Yes. And I do agree that the increase in the 14 and under is concerning. I do know that there are some special groups in the state who focus both on these youth populations, and we've also been seeing an increase in the focus in that older adult population as well. I know that one because I've been on some of the meetings with those, for those.
Yeah, those numbers pretty much track with youth mental health crisis, so it's very interesting. Those increases are higher.
Yeah. Do you guys have any other questions? Want to look at any of the other data that we have? Because we do have the assault data by county as well, if you guys want to look at some of those counties that we saw that were high. Okay. It's a quiet room today.
I'm definitely interested in seeing the assault map if you've got that. I'm curious how it relates to the other maps, if the hotspots are correlated.
The essence map or the one on the PowerPoint slide?
Either one.
Okay. We'll stay here. We'll start with the PowerPoints. So the PowerPoint is, like I said, it's a 5-year time period. And this is just all assaults, not by age.
Thanks. I think I missed that when you showed it. Sorry about that.
That's fine. And then we can also come over here to the syndromic data to look at the recent ones. And here's our, specifically our youth violence data. And as the red part, it means that it's increasing in these areas. So the percentage of the hospital population in that youth violence, some little pockets of places for intervention. Make sure. And then our child abuse here as well. And the difference between the youth violence is, I'm not great at that definition and I apologize, but it's mostly the youth violence is looking specifically at youth victims of assault, where the child abuse and neglect is looking more specifically at the abuse codes and the neglect codes. It's very nuanced. Theoretically, I think the definition for other the youth violence is looking at both the youth victims and the youth offenders. So.
Yes, the youth violence is primarily children. So anyone that is, a minor that presents to an ER for if they got in a fight or they fought someone, things more of that nature. It's primarily targeting the adolescent age category.
And does anyone have a specific county they want to look out for the assaults or the violence codes? Because we have several of the counties, not all of them, obviously.
Hey, Jacqueline, it's Beck. Can we look at Clay since it was higher in the other one?
Yeah. Perfect. Sorry if I'm making you dizzy on the screen.
Yeah, and while you're scrolling, we also, thanks to Andrew and Public Health and Kiprick, we have this for suicide data as well. Again, not for release, but for just kind of monitoring. So interesting and very important to see the overlap. So thanks for providing that.
Of course. And this is our Clay County data here. We see the youth violence here. That percentage is pretty unstable compared to some of these others, but decreasing. All right. There are no other questions.
So I guess, sorry, I have a question again.
Oh, go for it.
So looking at this data, like if
Mhm.
what would your suggestions be, or people in the room, like what would your suggestions be for kind of next steps in like investigation or action or prevention? Like what would you suggest this data be used to help inform?
I'm hoping it's used for prevention. That's where I want it to be used. But I think it's also really good for needs assessments. I know that some of the counties, they have needs assessments and they include this data. So I want to, this data is going to be used for needs assessments, prevention, even grant proposals. And if anyone wants to do a grant proposal, I'm starting to become a grant writing nerd. So I'm happy to partner with anything within the realm of intentional violence. And, you know, all of this stuff is where my love is for. And I say that in a room full of people who understand that me saying my love is for violence means research.
Yes.
But like I said, I'm hoping that it's used for prevention because we want to keep those numbers going lower. We want them to be, we want it to be used. We want the counties to know what they're experiencing. And sometimes it's just a validation of, yep, you're experiencing an increase in violence. Like, you know, I guess I talk about like the whole validating your feelings, but this is a validation of your trends.
I will add, so Louisville through a grant from the public health and then with Dr. Laura Fry and Dr. Becky Ansel from U of L, they're looking at specific fatality reviews just for Jefferson County. And one of the things that they've noticed is a large number of deaths in Louisville. I can never say it, precedent is listed as relationship troubles or relationship issues, and it kind of is in the line of what you're talking about with violence and interpersonal violence. And one of the things I asked them, where I worked before, we did a program called Love Notes, which was many folks might know about it on the call, but Dr. Fry also analyzed that as a suicide prevention measure, not just relationship health and, you know, decreasing interpersonal violence. So I just want to put that out there as a program that covers both relationship and conflict and suicide prevention. So I thought that was interesting. I don't know of anybody that's really doing it right now, but they have analyzed that program as effective in the past. So just wanted to put that out there for prevention.
Beck, we'll have to talk about that. This is Marcy, because I'm interested. Because relationships are the number 2 reason people take our screenings as well. And we have over 20,000 again last year. So.
Absolutely, Marcy.
Any other questions? No? Okay. Thank you all for letting me give you the information on AVERT. I hope to hear from some of you all about data and how we can partner for prevention. And if anyone has any further questions, wants a data request or anything like that, please reach out and email me. Here's my email, and I am happy to talk about this data all day long. All right.
Thank you, Dr. Seals.